Foundation Trust. Delighted to see so many members of the public with us this morning, particularly new governors today. Just to explain briefly the way a board day works for us, we have a board workshop in the morning, which lasts about 3 or 4 hours. So this morning we've been discussing our strategic update work, which is just being undertaken. We looked at the results of our staff survey, which we'll come back to later. We looked at, and we've been undertaking a bit of work with Better Boards, an independent consultancy, which has done a board assessment on us, which was informative. We had an update on Innovate Services, our IT subsidiary, and we had a session on cybersecurity. And that's what we've done this morning. We have the public board now, and then afterwards we have a confidential board where if there are items which are commercially sensitive, we discuss at that point. The way the board meeting works is you'll have seen if you've got a copy of the board pack. The board pack is sort of slightly larger than normal at 409 pages. So I tend to keep things moving forward at quite a pace because 409 pages is pretty consumptive. The working assumption is everyone has read the board pack. And at the end of the meeting, if there are questions from members of the public, we take them then. So that's the way we work. Welcome everyone. We have apologies from Charles Ashton, but David, I think, is deputising for him. So David, thank you for joining us today. I'm delighted to welcome some new non-executives to the board. So Phil, Roger and Pramjit, really pleased to have you on board with us going forwards. So, any new declarations of interest, colleagues? Please raise a digital hand. Can't see any digital hands raised, so we'll accept that as a no. The minutes of the last meeting held on the 2nd of March. Apologies, Gertie, you've raised your hand.
Sorry, Russell, my hand wouldn't go up in time. I just need to make the board aware that I do have a new declaration to make, which that I've been invited to sit on the boards of SWFT Clinical Service and Innovate Healthcare as a non-executive director. That's
great, thank you, Gertie. And Sarah, we come back to this anyway on the agenda, but Sarah, your hand is raised as well.
Sorry, mine was about the minutes of the previous meeting. I've just noticed on page 1, it actually says the date of the meeting's the 3rd of March, but it was the 2nd of March. Okay. The subsequent pages are correct. Sorry, I didn't notice that when checking.
Thank you, Sarah. So any other amends to the minutes of the 2nd of March? Please raise a digital hand. Okay, so I'll accept those as an accurate record. And duly sign them with that amendment from Sarah. In terms of the action points arising, we go to page 20 of our pack. The first was a copy of the continuity of care report to be sent to Mrs. Whelan Tracy. I think that was completed, so thank you for organising that. So if you could take your digital hand down, that would be helpful. And then on the integrated performance dashboard, leaving trends for staff to be included in the people section commentary. You're doing a deep dive on that, and that's going to be shared later on in the year. Is that correct, Gertie? Super, thank you. And then to ascertain whether recent new recruits into the trust would address the skills shortage in pathology. And then send the details to Yasmin. Gertie, that was done?
Yes, Chair, we don't recruit the pathology staff, and I have updated Yasmin.
Okay, great, thank you. And then on civility training, on the Freedom to Speak Up Guardians report, a breakdown of professional groups who have attended the training to be sent to Yasmin. That's work in progress.
Yes, it is, Chair. We don't necessarily have a record of all of the professional groups, so Sue and Deep are going back through the records to provide that.
Okay. Members of the public may not be aware, but we've got a big push at the moment on a programme called Civility Saves Lives, and the importance of civility in improving health outcomes, civility amongst staff. And so there's a training program going on there. And then Sophie to bring back updates to the green plan to the board on a regular basis. We've got to determine the frequency of that, Sophie, but you're going to do that?
Yeah, so that's scheduled for September and March, so it will come twice a year to board.
Super, thank you. And then on Glenn's report, Adam to be invited to a future board workshop to review the smart technology evaluations. We've got that organised for next month, so thank you for organising that. I think that's it in terms of matters arising. If you think I've missed a matter arising, please raise a digital hand. Okay, so we've got some items for approval first of all, and we've been discussing this a lot, Kim, over recent months, but the final annual financial plan and contracts. Over to you, Kim.
Thank you, Chair. So this paper sets out the financial framework for 22-23 and also identifies the assumptions and the risks associated with that plan. We discussed in more detail the basis of this plan at the confidential meeting at the last board. In Glenn's Chief Exec report as well, he's also highlighted some basis really for the overall national financial planning, which is on the basis that we're effectively living with COVID. The paper, as I said, sets out the fact that we are effectively setting out a break-even plan for the year, but that assumes that we will set a plan of a cost improvement programme of 3%, which is effectively at £10 million. This is challenging for us. It's higher than in terms of, it's a big number for us to deliver. So it is a challenge for us. But having said that, on a regional basis, they're still pushing organisations to deliver a higher percentage of CIP and remove costs we may have incurred in response to COVID. So work is ongoing. We're due to resubmit the final plan at the end of April, and we are, there's still a few things that we are trying to pursue to ensure that we can we're comfortable with the plan that we're about to submit. I've also set out in the paper further opportunities, as I said, that we're working through around income. We're also making sure that where we've got challenges around the surrounding areas where we see an increase in activity, whether or not we can pursue some sort of different contract forms to ensure that we again maximise the income opportunities there. But the big challenge is around our expenditure position. We're still, again, there's a work programme that's set out in the paper, but we're still building on that. And indeed, Simon Page has been correspondence where, is identified some other opportunities that we need to add on to the list. So they will be ongoing. I believe we've made an appointment now for a programme, a PMO support, so that will help us in terms of securing a delivery, and work is ongoing with the divisions to identify these opportunities and to drive those efficiencies. So what I'm asking the board to do really is approve the financial plan that we've set out and give delegated authority to Glenn and myself for any changes that may need to be made between now and the end of April submission, so that we can progress issuing the budgets of the divisions. And for the board to note, obviously, the risks and assumptions that we've made.
Thank you very much, Kim. So questions and perspectives. Glenn?
Just make a statement about the overall position first before I ask him a question for that. So yes, there is still a conversation going on between the integrated care system and the regional team about our overall deficit. I think we just have to bear in mind that we've got quite a challenging CIP plan here in our plan, and we are not in deficit as an organisation. So there's a whole debate around fair shares allocations, and I hope we move to that so that we can demonstrate we've got a planning figure for the next few years for our place-based budgets. But I don't anticipate that our position will change, because I think we would be looking for the organisations in the system that are in deficit to do better if we need to do better as a system. So the question, so Kim, on page 20 of 403, the waterfall chart, the descriptions along the bottom there, there's some missing detail for me, particularly around the business cases. So we'll talk a little bit later about some of the pressures that we're under as an organisation, but is there a bit more detail available on what we are funding as cost pressures?
Yes, we have some more details. I'm happy to share that with the board separately. I'm aware that there's a specific area around maternity that we need to ensure that the board is fully aware of. So we have set aside a sum of money to address the first phase of the business case for maternity. There is system money available as well, which is at the moment held at the system. So we need to make sure that we get our fair share element of that. But I've certainly set aside some funding on the basis that we're expecting to receive that funding to offset that. But certainly I can provide more details to the board outside of this meeting.
Thanks, Kim. And just to help maybe members of the public, one of the key measures in terms of cost efficiency and overall productivity of NHS providers is something called reference costs. Effectively, if your reference cost is 100, that means you're where you should be compared to the average. SWFT is consistently significantly below 100, meaning it's significantly more productive and efficient than would be expected. That's not true of the other providers in Coventry and Warwickshire, and it is not fair that SWFT is given the same sort of productivity improvement requirements, given its starting point, than those who currently aren't even at a reference cost of 100. Thank you for your answer, Kim. Rosemary?
Yes, Kim, whilst I know we discussed it this morning in the workshop, but I'd just like to place it on record for the purposes of the public. Obviously, inflation is running considerably higher than the figures which are in the plan. So could you just explain how inflation will play out in terms of the figures?
So in terms of the plan, so we've been asked to include in the plan based on inflation that we've been funded for. Anything outside of that is a risk to the organisation, but also is going to be sort of nationally picked up. So they want to understand what the figure is over and above that inflation assumption. So that's why we're kind of doing a bit more work really to separately identify the element that is over and above what we've been funded, so that the system can escalate those conversations really to the Treasury.
Kim, your microphone isn't in my ears working terribly well today. But you have very helpfully posted the fact that our reference cost is down at 88, which is exceptionally good. Any other questions to Kim? I would just make a more general point, which again we've discussed in the past. When foundation trusts were originally set up, one of the real benefits for foundation trusts was to be able to have liberty over the way it spent its own capital. So any depreciation which the organisation incurred and any cash surpluses that it generated would then be available at the behest of the board as to the way that money would then be spent. In an ICS finance regime, that is no longer the case. Our liberty over capital expenditure is limited by discussions that have to occur at ICS level on the allocation of capital. It's worthwhile remembering, though, that because we are not a PFI, we do need to reinvest our depreciation. So it's essential that as the financial regime of the ICS develops, that it is fair, recognising those organisations who are PFIs or have big PFI infrastructures, and therefore their replacement capital is paid for out of revenue, i.e. the PFI scheme, compared to us with no PFI, where we need our depreciation to renew our capital going forwards. So Kim has asked for delegated authority. If you're not happy to provide that delegated authority to Kim and Glenn, please raise a digital hand. No digital hands being raised. Duly granted, Kim, thank you. So we'll move on then to the capital programme quarterly update, effectively for the end of last year and the way things are going forwards. Over to you, Sophie.
Thank you. So I think it's good for us to just take a moment and have a look back on the year that we've had. I'm sure everyone's delighted that we opened our multi-storey car park, our surgical assessment unit to help the front door, and also our endoscopy unit, which was a really poor part of our estate. We brought it up to modern standards with ventilation, and I know a few members of the board have had the opportunity already to have a look at that. It has been a very complex and complicated year, which is why I really want to take the opportunity at board to thank a number of teams that are referenced in the paper, because it has been absolutely all the teams working across the organisation that have enabled us to deliver just under £23 million worth of capital and development programmes this year, which in my time now in this role, about 3 or 4 years, is the closest we've got to achieving the plan that we set. And that's in the context of a really challenging marketplace. So procurement has been absolutely essential as part of that to help us navigate some of that. And also the way the national funding has fallen this year. We really do have some exceptional teams that flexibly adapt and move so that we can achieve that. So start there. So big thanks to all of those teams. Moving forward, it's not getting any more, it's not getting simpler. It continues to be complex, but we are now in a position where we're being allocated 3-year capital allocations. This will help us plan more strategically. As a board, we've always done this because of some of the points that Russell's highlighted around being a foundation trust and able to take as a board some of those longer term decisions. I suppose the thing to note is we currently don't have our allocations approved. It links into what Kim's presented around another month, if you like, to finalise that allocation. So what this paper does is sets out the priorities and the order of those priorities in terms of main capital schemes. Within the main areas, essential maintenance, medical equipment, the CS schemes, we have also done a prioritisation within them to the detail, and that's been through management board. When we know our allocation, we will draw a line, and there will be things that we will not be able to do. At that point, it might be helpful then for me to bring something back on the next quarterly update on capital to just make the board aware of any risks that have come out of us not being able to do the programme that we've set out to do. So the board are asked to approve that in terms of that priority as it stands, and we will come back then once we know that allocation. And the last point is just we lost a month in the year that we've just had because we weren't able to move forward with any of the schemes because the same thing happened, that we didn't have our allocation approved. So Kim and I have had a conversation about bringing to board an approval for us to allocate now 4 million of our capital programme, which is an element of that total, so that our teams don't lose that month and we give them the best opportunity to achieve the plan that we're setting out. So that's here for approval today as well. And then just the final point is there are a number of things that the paper talks about being excluded. Russell has highlighted the explanation around our CDAL, so our limit on what we can spend. We do have a number of schemes outside of that that will form part of our programme. And the elective hub is probably the one to raise with board that whilst it's not in our capital programme, we're looking at alternative models that we can use to fund that programme. If that was unsuccessful, we will bring that back because we would need to, picking up on Russell's point again around CDAL and really investing in parts of our estate that need it. So the paper's here, hopefully board have had a chance to have a look at the detail in it, asking for approval on the priorities and approval for the 4 million, so we can give ourselves the best chance of achieving the programme this year.
Yeah, that's great, thank you, Sophie. Just before I invite questions and perspectives, I'd just like to make a general point. In my view, it can't be right, these sort of retrograde steps, taking away financial liberties from the top performing organisations in the NHS. SWFT is one of the top performing organisations in the NHS, and as a foundation trust we have thrived on behalf of our citizens in terms of the way we've been able to generate cash, reinvest that, which motivates our frontline teams and delivers better outcomes at better value to the taxpayer. So I am deeply concerned about this erosion of liberties for foundation trusts. There's frankly nothing we can do about it. Glenn and I have both made our views aware, but I still don't think it's right that we're in a situation where we can't fully invest our depreciation and any cash surpluses we generate in the way we decide as a foundation trust board. So with that contextualisation, questions and perspectives, Glenn?
Yeah, that's a good point, Russell, and we'll continue to make that point and continue to demonstrate how we get on with it. And that's one of the things that's worried me over the last couple of years, that we've got national level pots of money, regional pots of money, and now kind of system allocations, which slows everything down and adds a bureaucracy that often means that the NHS doesn't spend all of its capital, but spends half of the year worrying about how it's going to do it, and then misses the opportunity. So that's a frustration. But just to point out, so on the elective hub proposal, the regional team are meeting with the national team tomorrow to go through their proposals. Ours still sits top of the reserve list, and I've just had confirmation that the region will be allowed to add those reserve projects in if any of the others are kicked out. So I'll whilst I hope the regional scheme is supported, I'm obviously also quite like the reserve list. So we will see what happens with that. And just one thing to emphasise on the capital programme, unlike Kim's answer to the inflation problem on revenue, capital will not be subject to a reopening. So we're going to have to try and make sure we fit these schemes within the budgets that we've identified, which, as Sophie said, it's really difficult at the moment to try and predict the costs of delivering some of these schemes. So this will be a difficult ask to actually operate within budget for each of those individual items.
Okay, understood, Glenn. And we have discussed the priorities and projects in the past through our estates plan and strategy and elsewhere. Any other questions to Sophie? And Sue, and then we'll move on.
Yes, Sophie, thanks for pointing out that the total energy solution project is key this year. I know it's outside of this allocation. Any news on when and if that might be funded?
So we're expecting that scheme to apply for SALEX funding towards the end of this year, and we are currently on track with our total energy solution project. So we've gone out to market. We've changed it slightly, and we took the model that Y-Valley had done, but we're also working, and we've amended it to suit SWFT and what we need to achieve. And we're also working with Warwick University as almost a critical friend on that piece of work. So it's progressing well, and we should be in a position then to have a fully worked up case for when that opens this year.
Okay, thank you, Sue. Thank you, Sophie. So if you're not happy to approve the annual capital programme, including the 4 million that are being pulled forward, please raise a digital hand. Okay, thank you, Sophie. And can you thank the frontline team? They have done a brilliant job over the last year, and I'm sure they'll continue to do so. Duly approved. So then on to the Foundation Trust Code of Governance review. Sarah.
Thanks, Russell. So the board is required to declare compliance or non-compliance with the provisions of the FT Code of Governance in its annual report. I've undertaken a review of the analysis, is detailed for the board's consideration. I can confirm that all the non-execs up to the 31st of March are now deemed to be independent, which is a provision that we've previously declared as non-compliant. So I propose to the board that we confirm its support for the FT Code of Governance and that the board declares its compliance with all the provisions of the Code of Trusts in the annual report for 21-22.
Thanks, Sarah. Just for members of the public who may not be aware, previously one of our NEDs as a partner worked in the trust, hence that non-independence issue. Any questions on the Code of Governance review? If you're not happy to approve, please raise a digital hand. Duly approved. Thank you, Sarah. And then we've gone through the annual review of committee terms of reference with the chairs of those subcommittees. Over to you again, Sarah.
Thanks, Russell. So yes, each committee has considered its terms of reference and the proposed amendments are shown as track changes and required board's approval and ratification.
Okay, so all of the chairs of the subcommittees have been through this with colleagues. Any questions on those revisions to the terms of reference? If you're not happy to approve, please raise a digital hand. Okay, duly approved. Thank you very much. And so we're then on to the risk management strategy. We spent quite a lot of time talking about risk this morning, one way or the other. Anne, over to you.
Thank you very much, Chair. Just to recommend the risk management strategy for 22-27 to the board of directors. It's inclusive of the maternity department. It's been reviewed in line with the work undertaken by internal audit, the work that we've done at board of director workshops during the past financial year. And really the ambition of the strategy is to ensure the trust is able to move through the risk maturity levels, ideally to risk enabled, and that it will be able to manage its risks to acceptable levels.
No, great. Thank you.
Take any questions.
Any questions to Anne? Again, we've been involved in this in board workshops and elsewhere. You're happy with it as chair of audit committee, Rosemary? I saw you nodding. Super, thank you. Sue?
Yeah, not a question, just a comment to say it's really good to see the risk appetite appearing, and it was really helpful when we get onto the BAF to see that there against the objectives. So just thank you for that.
Yeah, and as Fiona's put into the chat box, it's great to see maternity specifically identified, and we'll be talking, Fiona will be talking a bit more about maternity later. So if you're not happy to approve the risk management strategy, please raise a digital hand. I can't see any digital hands raised, so duly approved, thank you. So we move then on to the annual review of directors' interests and non-executive director independence review. Back with you, Sarah.
Thanks, Russell. So the register of directors and register of directors' interests have all been updated to reflect the recent changes and appointments to board members. So they're attached for the board to formally receive and note. And the board's also asked to agree the independent status of the trust non-exec directors and endorse the treatment of this information in the trust's 21-22 annual report.
Okay, great. It's updated for Gertie's declaration at the start of the meeting, so thank you for that. Any questions on the director's interests and independence review? Okay, if you're not happy to approve, please raise a digital hand. Duly approved, thank you. And then on to the tricky one, fit and proper persons. Back to you, Sarah.
To confirm that you all are fit and proper. All declarations have been received and it's just to formally receive a note. Thank you.
My teacher back in Frian School in Basildon knew I was being described as fit and proper. He'd probably have a heart attack, bless him. Any issues on the fit and proper annual declarations? Okay, if you're not happy to approve, please raise the digital hand. Duly approved. And then we're on to the compliance statement for same-sex accommodation standards. Fiona, back with you.
Yeah, thanks, Chair. I'll take the paper as read. It's our annual statement of compliance. As you can see, we have declared 2 non-compliances or breaches of the guidance related to capacity pressures in CCU. That's not an unusual number for a year's compliance statement for us, so I'm comfortable that we're still in a providing dignified and good experience for patients.
Okay, thank you very much, Fiona. Questions and perspectives, Glenn?
Just to commend Fiona and the team, actually, and Harkamel's teams as well for that, because actually the data elsewhere in the NHS, there have been a lot of breaches over the last year because of COVID restrictions, and certainly we've seen that elsewhere in the group. So to have only had 5 patients affected is exceptional.
Okay, thank you, Glenn. Any other questions on the same-sex accommodation standards? Members of the public may sometimes wonder why we have to go through all of these type of issues in our board pack as frequently as we do. It is a national requirement of NHS boards to go through this type of detail. So if you're not happy to approve that compliance statement, please raise a digital hand. And then on to a interesting one, the Infection Prevention and Control Board Assurance Framework. Fiona?
Yes, so to bring up that point you've just made, the amount of detail that we have to go through. So I am hoping that you've read this. It is very lengthy report. It's a standard template that comes down from NHS-IE. It has been refreshed in the last 6 months, and the areas of yellow are the areas that have changed or been updated in the last edition. I put a lot of detail in there in terms of our compliance. The board will be aware that we are just going through the IPC policies and guidance within our own trust and just reflecting the current position actually in terms of the pandemic, and we'll be bringing to board some decisions that possibly are more pragmatic, bearing in mind the nature of COVID now and the impact it's having both in organisation flow but also to IPC. So this is a point in time against the national guidance that are, but with the knowledge that they were likely to be changing again fairly frequently and imminently. And if not, then we may change our internal ones anyway.
Okay, great. Thank you, Fiona. So I do want to separate that issue because I know Glenn touches on it, but it is worth, again, just reminding members of the public that the infection prevention control protocols around COVID probably cost us, including the staff absence related issues, something like 5 to 7% of our capacity. So these controls are not irrelevant when it comes to our ability to really drive into the waiting times that we know exist for our citizens. Any questions on the detail of the IPC Board Assurance Framework? Okay, if you're not happy to approve, please raise a digital hand. Duly approved, and thank the team down the line, Fiona, because they do a great job on our IPC. And then we're on to the annual review of KPIs, including quality indicators. We do look at these every year. Harkamel and Fiona, over to you.
Yeah, so we've taken the dashboard and reflected the requirements set out in the latest priorities and planning guidance. There weren't as many changes as you would have seen last year, but the ones I just wanted to draw out were, although from the regulatory perspective, we don't have to now report the 92% of 18 weeks or the number of patients on the waiting list or the patients waiting over 52 weeks. I propose that we keep those in because the additions are all around 78 weeks and 104 weeks, and that just feels like we're striving for excellence, and we didn't want to lose sort of track of that. So we've kept them in and added in the new ones. We've also amended some of the targets where the elective activity needs to be set at 104% of the 19-20 outturn. and reduced it for follow-ups where it needs to be set at 85%. And then the only other thing I wanted to draw everyone's attention to was around the maternity targets. So we have removed a target for the maternity elective cesarean section rates, emergency section rates, and vaginal birth rate. But we propose that we keep them in just so that we have a method for tracking and don't lose oversight of them.
Super, Harknell. Thank you. Fiona, is there anything you'd like to add?
No, Harknell and I've agreed on that stance, so happy with that.
Okay, thank you. So questions and perspectives, Glenn?
I've got a bit of a plea, Harknell, which you may not thank me for, which is I still struggle a little bit with some of the indicators that are percentages. And I think absolute numbers alongside those percentages are often more meaningful. So there's something about presentation, and you know, this is probably more for Kim with the information team. The absolute numbers are helpful, particularly when we're talking about things like, you know, cancelled operations, a percentage versus how many patients have been affected. I'd rather see the number as well.
Yeah, okay, I'll do that.
Point well made, particularly when it's small numbers and it can swing the metrics enormously. I think it's really good, Harknell, that we keep our focus on RTT, 18-week. I do worry that in a post-COVID world, the whole standards are being dumbed down, and I want us to get back to that 18-week RTT 92% as soon as we're able to, and hold ourselves to a higher standard than others. After all, we are the only outstanding CQC rated acute in the Midlands, and we need to hold ourselves to a higher standard. Any other questions or perspectives? Sue?
Yeah, just had a general point, which was that there's there's a lot in here. There are still a lot of measures, and you know, net we're adding rather than subtracting. Sorry, my dog's just jumped on me. Slightly distracted. And secondly, so just a plea that I know there's work going on across the foundation group looking at a set of measures that we look at. So, you know, we don't necessarily need to see all KPIs at board, although they may all require looking at within the organisation. And secondly, just thinking ahead really, I don't find these measures that easy in terms of how I triangulate them with the left shift. So, for example, is virtual ward acute activity or is it outpatient activity? So I just think that over the course of this year, we need to really be thinking about how we're going to demonstrate progress against that key strategic, key strategic move, because it seems a bit offset from the key things that we look at.
No, great point, Sue. Great point, thank you. And David Spraggart?
Yeah, I just wanted to go back to the maternity, the cesarean section rate target. I mean, it is good news really that it's been removed as a target, and I'm sure Ockenden is the driver behind that. But I just wanted to reiterate how important it is for us to keep a track of that, because I think that it is a quality indicator to some extent, and actually we can demonstrate that we are intervening safely and allowing mothers to have safe births, which perhaps is contrary to what the target was driving us towards. And I think that's it. People that haven't read the Ockenden report can see that the cesarean section rates at Shrewsbury were considerably different to ours, and I think that it's important to flag this, because actually we could demonstrate that for a long time we've actually functioned what we would consider at a safe level.
Thank you, Dave. You want to come in on that, please? Okay, Harknell, your hand was up.
Yeah, I just to respond to those 2 points. So, David, it was actually the conversation that you prompted at board, I think it was last month, that sort of informed the thinking around keeping the metrics in, but removing the target so that we don't lose oversight of it. And just to respond to Sue's point, I think you're right. Actually, there are a lot of indicators in here, but I think we need to remember that this is a tool for us to be able to measure so that we can manage. And actually, it's sort of it's our role as execs, isn't it, to try and triangulate some of that. So I think Fiona and I can definitely take that away through the establishment of the Left Shift board, and we can think about how best we reflect those conversations back and give you some of that oversight of how they actually all do meet to tell that story, perhaps in a bit more of a real way than the dashboard does. But as a tool, you know, it is there to sort of just help us have that oversight.
Okay, thank you, Harkema. And finally, Glenn, and we'll move on. Oh, sorry.
Yeah, so my point was on Left Shift, actually, which is a really good observation by Sue. I think for me, Left Shift is the setting rather than the service. So, you know, increasingly, we ought to be able to look at delivering acute interventions virtually or into patients' homes to support them not being in hospital. So I think there's maybe just something about totaling up those and having some sort of ambition to change the balance overall, which we could monitor.
Yeah. And it will be an interesting measure over time, the average cost per night of us looking after a patient as we left shift more should reduce significantly. And finally, Paramjit.
Thank you very much. It's sorry to add something else maybe to the list here, but it really sort of plays into your conversation about easy access and the left shift. It's the late presentation of women. They may be small in number, but the women who present late are more likely to get complications and more likely to get interventions. You know, maybe that should be, if we're pursuing for excellence, you know, to have that as an indicator.
Okay, great, thank you. And did your hand went up?
I think I was just about to put it in the chat. I think that level of detail is reported into clinical governance. You know, there's a level down or several levels down of detail that comes up through board. So it might be once you're familiar with the AOG reports. I've got a feeling it's in there, but I will check.
Okay,
Yep.
I think it's in there as well.
It is. It is.
Yeah, thanks, Jeff.
Definitely is.
Okay, team. So if you're not happy to approve the revised KPIs given the points we've made, please raise a digital hand. Duly approved. Let's go and deliver the performance now, guys. So we're then on to the performance review and assurance part, the first of which is Glenn's view of things. Glenn, how are you seeing things?
Thank you, Chairman. We noted your ambition to deliver the RTT standards earlier than anyone else in the NHS. Quite a few things in the report here, but one thing that isn't in the report, which I'm very conscious of, is that since we produced this board pack, the second Ockenden report has been published, and we've mentioned that already. Suffice to say, it will get a lot of focus in our next board meeting and in future board meetings. It's a shocking report, and one that the whole NHS needs to learn from, both actually from a maternity perspective, which there's some very specific issues relevant to maternity, but also from a cultural transparency perspective as we deal with all services in the organisation. So we'll be coming back on that. And in fact, yesterday we had an inspection from regional colleagues on where we were as an organisation with Ockenden, and that was incredibly encouraging in terms of the cultural issues that they explored with us. But we'll share that with the board and share that with the public. So a few things just to highlight. Firstly, we've already talked about infection prevention and control. I highlight here the fact that we are still working with a national level 4 incident, and we're still using some IPC rules that were set up for earlier waves of COVID. And obviously, fortunately, the impact of COVID has changed. It's having a milder impact on individuals. But at the same time, urgent care is under pressure, and we'll talk about that as we look at the performance report. We have capacity constraints because of infection prevention rules that we're applying, and because we also have staff isolated who are asymptomatic. So there's a number of trusts that are looking at this. The national team have been looking at this, and we've been trying to influence them, but they have encouraged us, if we want to look at the balance of risks locally, to vary those protocols. So we're reviewing that now. It'll be very clinically led within the organisation, but also across the group, and that's something that we may want to come back to the board on, as Fiona suggested, in order to approve some variation to those rules. And then secondly here, actually, and linked to that, we're not going back on maintaining very high levels of infection and prevention and control. So one of the things that we will continue to do across the NHS in care settings is to enforce mask wearing. This has been a little bit contentious over the last couple of weeks. We had an incident within the organisation where an individual refused to wear a mask who was medically exempt, which we absolutely understand there are some individuals who are. So the individual was offered the opportunity to wear a visor and then declined that also, which we felt was a risk that shouldn't be ignored. It wasn't a life-threatening condition because, of course, we would respond under those circumstances, whatever the individual was doing regarding infection prevention control. But our staff did the right thing. And what I wanted to say here is we need to support our staff to make it safe for them, make it safe for other patients. And we will continue to ask members of the public to wear masks. We haven't got a mask wearing law anymore, but we've never had law associated with our other infection and prevention rules and guidelines. And so we would ask that members of the public comply. And if they don't want to be treated safely, then they're declining treatment rather than being declined treatment. Moving on to elective recovery, I knew it was probably a bad idea to make the statement here that no patients have been cancelled across the group due to Operation Ring Fence. We're still holding that line here at SWFT, which is great, and we've got a really good track record. Elsewhere in the group, it's been a very challenging week, and we'll talk about this later on. But we've had to move into a protocol of ambulances doing immediate handover of patients at the front door so they can be freed up to go to the next patient rather than waiting to be accepted. That's put all sites across the Midlands under pressure, and it has led to a small number of breaches. I have to say, across the group, the numbers of bed-related cancellations are still really low. We, though, as a trust and actually as an integrated care system, have delivered really well on the elective recovery statistics. So no 104-week waits at the end of this year. And we're marching on, aren't we, Harkamel, to have no 52-week wait breaches by the end of Q1 of next year, which is well ahead of the national expectation. And what my report goes on to say is we're using 52 weeks as a bit of a threshold below which we will offer mutual aid to other parts of the NHS, particularly neighbouring organisations where their waits are longer. But we will seek to guarantee that we'll not go beyond 52 weeks for our local patients. And we're already looking at helping Herefordshire with orthopaedics, and there are other pressures around us, including the Birmingham system, that we're seeking to help also. I won't go through everything. The Purpose Health Coalition tomorrow will be launching that report that will create a great deal of focus around the levelling up agenda within our place, and we look forward to some further discussions about what that entails for us in terms of things that we'll tackle. I talk about financial plans, which we've covered. I talk about capital. That system level capital discussion is quite pressured because, as you suggest, Chairman, the level of resource that is generated internally by organisations based on their own asset base it creates a bit of a fair shares allocation for each of us, and we're seeking to operate within that. But there are elsewhere in the system trusts who have got some other capital requirements that go beyond that, which would consume most of that allocation. So we're trying to delicately negotiate our way through that to ensure that we actually can do the things that are set out in the plan that Sophie took you through earlier. And then finally, there's an update on data security, and we had a really good update in our workshop this morning from Adam talking about how Innovators is settling down as an organisation and very professional approach to their strategy and their focus. And we also looked at how we're doing against some of the cyber threats earlier as well, which was reassuring also. So lots of good things going on in that place. Happy to take any questions.
Thank you, Glenn, and thank you for your hard work, Glenn, on the national debates that go on behind the scenes. We know you contribute fulsomely to a number of different issues, including discharges and the way we work with primary care. Any questions to Glenn? Discussed a lot of it earlier on in different forums, I know. Okay, thank you, Glenn. So we'll move on then to the integrated performance dashboard. Over to you, Anne.
Thank you very much, Chair. So the commentary really draws out the key areas of note for the month 11 position. And if I may hand over to colleagues now to go through their sections in detail. Okay,
that's great. Thank you. Colleagues have to go into the detail, starting off with Fiona. So Fiona, over to you first then.
Thank you, Chair. I haven't got anything really to pull out today other than to say all of the quality and safety metrics within my report are continuing to be very stable, and I think that's remarkable in itself given the pressures within the organisation over the last month or two. So we're in a good place from a quality point of view. My ambition is still to drive continual improvement, but given the pressures that we're seeing, I think this is a good reflection of the work that the clinical teams are doing.
Okay, great. Thank you, Fiona. Any questions to Fiona? Talk to me a bit about pressure ulcers, Fiona, and how you're feeling about pressure ulcer performance.
I'm comfortable with pressure ulcer performance. We have had some spikes both in community and acute over the last 6 months or so, but it's not an ongoing trend. We have done a thematic review, particularly in the community, when we had the first 2 lockdowns where we did have to prioritise patients on the caseload in community. There was we did see an impact in terms of some people with long-term conditions and a spike in pressure ulcers, but that hasn't been an ongoing trend.
Okay, that's great, thank you. Again, just to help new governors, pressure ulcer performance is a really good measure of underlying care. So it's always worth looking at the pressure ulcer metrics if you want to see what the level of underlying care is like in any NHS organisation. Any other questions to Fiona? Otherwise, we'll move on to Harkamel. Harkamel, over to you.
Thank you. So February, in terms of A&E performance against 4-hour standard, we were not far off January, so we achieved 69.4%. We did start the month off very well, but that dipped as the month sort of went on. That just places us as 33rd of type 1 providers. So although this performance is lower than we've ever seen and lower than we would want to see, that puts us on the 75th percentile of providers. And just to kind of build on what Glenn was saying, that was mainly as a result of sustained bed pressures. Flow was really challenging. Medical bed occupancy reached just under 94%. Sundays and Mondays continue to be the most busy days for us. And actually, in terms of bed pressures, I'd say February was one of the most challenging months that we've had when you consider all the bed closures that we had due to COVID. So we were really hampered in terms of where we could move our patients to. We were really affected by and continue to be affected by the community beds in terms of where we can step down to, but we did see a number of closures in February. And we also had to bed into our ambulatory areas to keep our hospital safe, which impacted flow further. And to try and combat that, we had several MAID events throughout the month, which we've tried to make a lot more intensive, and are planning one for next week just to get us hopefully in a better position for the start of Easter. Our non-elective spells increased. We did expect that anyway after the lull of sort of December and January. But when you factor in all of the working days, actually that number sits closer to the peak that we saw last May and June, which were incredibly busy for us. Exit delays persist. So as of today, we have a total of 42 patients in the acute who could be elsewhere. And we've actually declared an internal incident just within community services today, just to try and push some of those patients out and have absolutely everybody just focused on trying to manage that with the community team. Cancer, remains stable. So I think I have said previously that although our cancer performance isn't where we want it to be, stability is what we're looking for at the moment. We're certainly not seeing those peaks and troughs that other organisations are seeing. So that is an indication of some of the grip that we've got of our cancer performance. And that said, we do remain challenged, and moving forward, I'm making some changes to like the governance just to try and track some of these patients in a different way to try and achieve the success that we did around the 104-week waits. That said, although we achieved 62% for our 28-day in January, we actually achieved 73.4% in February. So that's a marked improvement on our performance. Colorectal and urology remain a challenge. And finally, just in terms of elective restoration, we managed to achieve 99.8% of clot stops. And against the operational performance that we've seen in February and against the backdrop of A&E, that is incredible. So I'm really, really pleased that we managed to retain our grip on that. And just as a flavour of what we are working towards, we've currently got 11 patients waiting over 78 weeks who are undated. So just 11, so we are working through those now. And as Glenn said, we have got a plan to try and reduce our 52-week waiters by the end of the first quarter. Our biggest pressure point with that, though, is orthodontics. So after that, we've got just under 30 for ophthalmology and urology, but orthodontics really is the brunt of those patients. And that is a problem nationally, and we continue to escalate to try and get support for that. But I think that's a more comfortable position than we could have been in, so I'm happy with that. And we have had no 104-week breaches. I know I've said it twice, but it is a really big deal, so I want to say it again.
Well done. Congratulations. It's also worth, because I don't think I heard you say it, but I think in this month, our volume into A&D compared to pre-COVID was up between 10 and 30%.
Yeah.
An enormous increase. So when we look at our A&D performance, it needs to be contextualized in terms of the enormous increase in volume, which we don't think is going to decline. Questions or perspectives? Glenn?
Yeah, could I just make a couple of points? Firstly, on that one, Russell, we've been looking at the data, and there's a material capitation change in terms of our catchment area. So we're seeing quite a bit of activity coming from Solihull. They had an urgent treatment centre that closed due to COVID, so we'll be trying to find out whether that will reopen at any point, because that demand is impacting on our flow. And the other one is, you know, and I've raised this with the national team, a bit of a concern that the currency around elective recovery is all about percentages of your previous activity baseline, so the 2019 baseline. So everyone's talking about, you know, we're doing 100%, we're doing 104%, we're doing 98%. Our baseline was high, our productivity was high in 2019, and there are organisations that were cancelling quite a lot of activity at that point, mainly because of urgent care. So just as we look at our, you know, trying to do more than 104%, it will be a challenge for us. It will be easier for some other organisations.
Yeah, and they need to be held to account to deliver those relatively easy benchmarks. Thank you, Glenn. Any other questions or perspectives? Fiona?
Yeah, apologies, Hardcombe, but I have only just seen this. So I think it's a message back to Kevin and the information team. There is still a RAG rating against the maternity measures in the dashboard on page 4, and I just want to make sure that the public really recognise that we aren't targeting a decrease in emergency caesareans or an increase in normal birth. Our strategy is to provide choice and go with the safest method at the time. We need to take that colouring off all of those measures if we can. And I would say that under the CQC domain that they should be labelled safe rather than effective, actually, given the Ockenden outcome.
No,
Yeah.
Two great points. Thank you, Fiona. And any other perspectives? When I noticed in the Stratford Herald that the minor injuries unit is due to reopen over at Stratford, do you think that will help us much at the A&D in Warwick?
No, if I'm honest, no, I don't think it will help us much. When we've looked at the data of where our patients are coming from and the acuity that we're seeing at the moment, those patients would not be fit to be, we couldn't manage those out at Stratford. And I think that's the bit that sort of gets lost in a lot of this. So I think I've said in previous updates, and I perhaps need to do some further thinking of how I can better represent the acuity as well as the volume of patients going through A&E, because I think that might help tell some of that story. But in my opinion, I don't think that will help us.
Okay, thank you. And finally, Sue, then we'll move on.
Yeah, well done on the 104. Hitting that, fantastic. I just wanted to replay one of my pleas around the 28-day faster diagnosis. So I agree, it's positive that we're moving towards it and gripping, but we do need to understand when we're going to hit it, and it would be great to know what I hear what you say around doing some of the work to potentially on cancer to potentially have an impact similar to 104-week waits. But I know you're balancing a lot, but I know there's been some modelling, and I'd like to understand when we think we're going to hit it.
Back with you, Harkamel.
Yeah, we are working on that, and you are right, there is modelling. So if it's all right with you, I will maybe organise a session with you offline to go through some of that detail and think about how we might best present it back, if that would be okay.
Okay, great. Thank you, Harkamel. Okay, we'll move on then to Gertie's report. Gertie, what would you like to pull out?
Thank you. I will say recruitment continues to be, a key risk for us and a real area of challenge. And we can see that we've had some positive, that we've had international nurses and a number of new starters. What I think I will do is ask that we have a bit more clarity in the report about the number of staff coming through pipeline with confirmed dates, because I'd like to assure the board we've got, in terms of registered nurses, there's over 100 staff who've been interviewed and offered and are working through their pre-employment, with 29 of them already having a start date confirmed. Equally, clinical support workers, we have working with system colleagues on this, but again, we have 94 in pipeline and nearly 20 with confirmed start dates. The team have identified additional recruitment activity, so going to do really focused open days to really engage with the public and with individuals wishing to work with us. So I would hope to see that this position continues to improve. Very positive. I've had an update this week from the work we've done jointly with Fiona's team, that we've put a lot of activity around recruitment, and we're seeing real improvements in our time to hire. And again, we'll include more detail next month on that, Chair. Glenn's already covered the challenges around sickness, particularly with COVID and isolation. We are working to make sure that those are all supported through the FPE, and again, appraisal then statutory and mandatory. We are not where we want to be at the moment. These are areas that for COVID we chose to step down in a number of areas, and we're working with Hartmel's team through the finance performance meetings to make sure we have robust trajectories and plans for when they will be back online. So that's all I'll pull out, but thank you, Chair. Okay,
thank you, Gertie. The line is a little bit granular from your end, so it may be an idea to turn your webcam off just to improve the quality of the audio. Any questions or perspectives to Gertie and David?
Yeah, I just wondered, have you got any more detail on the reasons why the appraisal compliance isn't picking up? I mean, is it the people being appraised that are the issue, or the appraisers that are being? I'm just interested to know why, because this seems to be an ongoing problem, and we don't seem to be getting any closer to achieving the targets.
Yes, David. Oh, I've got really bad feedback. Sorry, I'm not sure if you can hear me okay. We talked through quite a lot of this in granular detail at the most recent finance and performance meeting. It's particularly challenging in a number of areas because of gaps of vacancies and sickness. We are assured that we have now got more robust plans in place around making sure there is scheduled time every week on week to start catching ourselves back up, and the divisions have got plans in place that vary between getting to compliance between May and July for the more challenged areas. So a lot of it is around availability of both individuals to be appraised, but particularly the pressure around staffing, because people are making the right decisions from a safety perspective not to pull staff out, But again, I would say this as the HRD, my argument is that appraisal is a wellbeing conversation and contributes to good care. So we're getting the balance right, and I do think we will start to see this slowly shifting up.
Okay, yeah. Thank you, David. Thank you, Gertie. Colleagues, have to move on. So, Kim, we're effectively at the end of the financial year. Do you just want to summarise where you think we'll be?
Yes, of course. For the benefit of some of the new board members, we set a financial plan for the year to deliver a break-even position. Our year-to-date position is delivering that. My current forecast outturn is well, I'm expecting it to be on the right side of that break-even position. So that's where we stand at the moment. Board members will recall at the last board meeting I had raised the issue that we were in discussions with the regional NHSIE team about the treatment of an accounting standard change for the treatment of intangible assets, and that might result in a technical deficit. We have worked through that with the regional team, and they have confirmed that that they will accept that technical accounting change, and that will mean that we will be reporting a forecast outturn of a £3.5 million deficit. But they have confirmed in writing that this will not have any detrimental impact on us in terms of the single oversight framework or our segmentation rating. So we're obviously just working through that, and we've reflected that in the year-to-date position, both on the statement of comprehensive income and also on the statement of financial position or balance sheet for most of us people who still remember it. That's probably all I wanted to highlight for now, Chairman.
Thank you, Kim, and some helpful charts on productivity and consultant episodes, which is all very interesting. Thank you. Questions and perspectives, Glenn?
I'll always call it a balance sheet, Kim. Just on that point, obviously we have to comply with accounting treatment changes, so that's an important element of this. But also, Kim, I think it's worth emphasising that change reduces our depreciation in future years and actually has a benefit in future years, doesn't it?
Yes, sorry, yes, I meant to draw that out. So yes, it does. So the derecognition of those assets will give us a reduction in the amortisation for the next 3 years, the detail of which we're taking through to audit committee next week in terms of all the technical accounting changes. I didn't want to highlight it in the main board report, but it'll go through audit.
Richard, you will spend many interesting hours now getting to know NHS financing, so you can enjoy that as part of your journey. Any other questions for Kim? I guess one of the worrying trends, which we'll come on to in just a second, is our use of agency is still becoming a problem, which we need to be very careful about. Finally, Rosemary, then we'll move on because we're running a bit late.
And just to clarify, this accounting changes will apply presumably to most NHS organisations as well. We're not unique. Yeah. Okay, thank you, Rosemary. Thank you, Kim. So we'll move on then to the mortality report. David, do you want to pull out anything particular on this? Come in, David. Okay, we'll maybe come back to that a bit later then. So we'll move on then to the monthly safe staffing report. Fiona.
Yeah, sorry, Chair. Just before we go on to that, can I? Is it a good time to give an update to the board about Ockington?
I think that would be great, Fiona. Thank you.
Okay, so as you know, and the public knows, that we had the second Ockington report published on Wednesday, which we are obviously reviewing and developing our an action plan and improvement plan against. But reassuringly, we had a visit from the regional NHSIE team yesterday as one of the first providers in the country, actually, and they are planning on going to every maternity provider to review progress against the first Ockington report and the immediate actions that we needed to take against that. It was actually a very, very positive visit, and they gave us feedback which was of significant assurance, level of assurance that they had. They spoke of being very impressed with the leadership team within maternity, particularly the MDT, the multidisciplinary working between obstetrics, neonates and maternity staff. They talked about every member of staff that they talked to, including ISS staff, student nurses and senior staff, all saying that they would speak up and raise patient safety concerns and did not feel that there would be any detriment for them to do that. They all knew how to report incidents and safety concerns as well electronically if they didn't want to speak to somebody or felt they wanted to do both. They talked about the board and all the way down from the board to the frontline staff, all singing from the same hymn sheet. They talked about saying the same thing. We've got some pressures, but we are improving and we're safe. And a very open and honest culture throughout. They were impressed with our trajectory against our staff's training and assured that we are making progress on that. They were again very pleased to report that our student and our midwifery staff experience and well-being was reported to be very good. There was a small number of areas for improvement, mainly process issues rather than cultural. And if you have read the Ockington report, I would say the standout message through Ockington is cultural, is safety. Culture is staff not being able to raise concerns, not being listened to, as well as the patients not being listened to. And they again were impressed with our relationship with the Maternity Voices Partnership, which is our patient group. So we do need to do something around our guidance, our guidelines, our audit programme, and some more communication around some of the leadership roles within maternity. But I'm pleased to say that it was a very good visit. We will receive a report in the next week, and I'll share that with the board when it's available.
Great, thank you, Fiona. Just to state something again, which has been said in the public domain before, there is a very clear focus from the board downwards into the maternity teams that our priority is the safe delivery of healthy babies and the well-being of mothers. So that has been a long-term focus for us, but we do recognise that childbirth is an inherently risky, potentially episode, and also there is a national shortage of midwives. But in that context, that's a very encouraging report. Thank you, Fiona. So moving on to the monthly safe staffing reports.
Yeah, so this is a standard report that the board sees every month that just demonstrates our position against our planned staffing levels and those that were actually worked. It's a fairly static position. You can see over time there are areas of concern that we put improvement actions around. This month it remains theatres, to a certain extent maternity, but that driven by maternity leave and sickness rather than vacancies now. And some of the smaller AHP teams have some significant vacancies as well. But you've heard from Gertie's report, our recruitment is strong, and we continue to support those teams that need that. So I'm comfortable that we have a good grip on maintaining safe staffing levels through the organisation on an ongoing basis.
Thank you, Fiona. Any questions to Fiona on the safe staffing report? I guess the only point I'd make, Fiona, is that issue of the amount of agency we're having to use because of absence, and that is a practical and a strategic concern as well. Because I know on the front line, one of the anxieties that staff have is when the agency nurses are on the wall, so to speak, they often are given the easiest of tasks because the teams have got less confidence in them because they know them less well. So it is a practical issue. I know you're wrestling with.
Yeah, so we have, sorry, Chair, we do have a case coming through confidential just because of the commercial sensitivity of the paper today, which I'm hoping for board approval for investment into recruitment and retention strategies.
No, fantastic. Okay, if there are no questions, Fiona. David, I apologise, I caused a level of confusion with the two Davids.
Yes, it wasn't me. It wasn't me you were after.
Mortality another time. But David, over to you to go back to the mortality report, and apologies for the confusion I caused.
No, thank you, Chair. So I'll take the go on the safe working report as read. I think the key points which lead on very clearly from the discussions we just had with Fiona is that we're needing an ongoing large number of locums to support the medical workforce. This has been primarily because of COVID affecting individuals, but also because of contact isolating individuals. To support safe patient flow, we've provided additional weekend shifts, and these have required locum cover. To support the safe isolation of patients, we've had additional ward openings. Due to recruitment difficulties with Health Education West Midlands, we've had a reduced number of trainees, leading to vacancies, and this has been a particular problem with our GP trainees, and unfortunately we've often had late notice from Health Education. In addition, Health Education has asked us to provide trainees with additional opportunities for training, which has led to further vacancies. We've noted in the report an additional number of exception reports because trainees are finishing late, and I think this reflects their commitment to work with clinical teams, medical nursing and AHPs to cover wards and to make sure that rotas are not left vacant. The Trust has mitigated against these challenges with clinical education fellows in general medicine and general surgery. These have really helped cover gaps, but haven't been able to cover all the gaps that have arisen. Strategically, we've changed the obs and gynae and surgical junior doctor rotas to reduce dependency on GP trainees. We're developing new rotas for our emergency department to support rota compliance. And I'd just like to take this opportunity to thank the exceptional efforts of our medical staffing teams who have literally worked around the clock to help clinical teams. The support from all the clinical teams, including agency staff who've come in at very short notice, and management board who've really helped us prioritise patient care despite the challenges. Happy to take any questions.
That's great, David. Thank you. That's a very helpful contextualisation. And can you pass on our thanks to all your colleagues on the front line? Any questions to David? Gertie?
Yeah, thank you, Chair. I just really wanted to echo the notification and the thanks that David has shared for the medical staffing team. The medical staffing team are themselves a very, very small team. They've been impacted personally by sickness, by COVID and by isolation, and despite that they have worked tirelessly. The number of gaps through banking agency they have filled is truly phenomenal, and I do think it's just worth particularly noting again our thanks to them, and I'll pass those on to Andrew and the team, so thank you.
Thank you, Gertie. Thank you, David, and thank you for, as I said, your hard work. We're running a bit late now, guys, so we need to pick up the pace a bit, please. Thank you. And the Clinical Governance Committee report for the 9th of March. David, what would you like to pull out?
I mean, I take it as read. I mean, the only thing I want to keep the board's attention on is the management of children in crisis on McGregor issue has not gone away. And there is still work being done on it. That will be followed at our next clinical governance meeting. We've had lots on it up to now, but I think we mustn't forget that it still is an issue.
Yeah, no, I think that's a really, David, because it's being got as an issue by some colleagues in the system. Any questions to David on the Clinical Governance Committee report of the 9th of March? Okie dokies. Then we've got the Foundation Group Strategy Committee report for the 22nd of February, which obviously take as read. Anything you particularly like to emphasise?
Nothing to emphasise really, Chair. Only to say I think it's some very good evidence of collaboration in the meeting, some good projects been run, and I think the addition of Worcester Acuity is a good addition to the group as well. I think observations.
And for members of the public to be aware, we did have a 3 board meeting last week where we brought together 3 trusts in the Foundation Group to discuss the way things were going, which was again a good session. Any questions to Simon? Okie dokie. So then on to the annual report of signings and sealings. Sarah.
Thanks, Russell. Just to formally receive and note this report, please, and highlight the significant amount of documents that we've signed and sealed this year.
I know, extraordinary. Your old right hand must have been stamping away with enthusiasm. Any questions on the signing and sealings? Glenn's signature as well. Okie dokie, so thank you, duly noted. So we're then on to our end of year report for Glenn.
I do like it when we get the seal out. It's very old fashioned. Anyway, Chairman, so at this point each year we look back on the performance against objectives, and this goes into the annual report. So what we have here is a year-end position against the objectives we set for this year. We have set the objectives in close collaboration with our governors, and in our quarterly Council of Governors meetings we also provide an update on progress. So this reflects those updates. I always say this because it's true that there'll always be some objectives that are amber or red rather than all green. If they're all green, we're not stretching ourselves enough. So there's 1 or 2 ambers here. There's no reds this year, but there's 1 or 2 things highlighted that we would have liked to have made more progress on. I'll just quickly go through those if that's okay. I mean, firstly, on the transfer of tertiary services, that has not improved significally. Obviously, it's been a difficult year of bed pressures for colleagues at UHCW, and when things normalise, we will hope to continue to ensure that those transfers happen effectively. The new urgent care model you referenced earlier, the minor injuries unit, we will reopen that, but as Harkamel alluded to, we do need to look at the functionality of our urgent care system and make sure that all points of access are taking appropriate capacity. The Foundation Group data-driven approach, some good work on improving the information function, which has been shared with board, but we need to get into the meat of actually using the data at place level in all 3 trusts in the group in order to make change happen. And then otherwise, a green set of things which I won't take you through.
Okay, thank you, Glenn. Any questions to Glenn on this sort of end of year report? Rosemary.
Hi, Glenn. I just wanted to check, so that all the points which were amber are all things which are essentially still work in progress, and it's really important that we have a mechanism to continue to focus on them. Now, some of them effectively roll into this year's objectives, but not necessarily. So I just wanted to be clear as to how we keep a grip on these objectives.
Good question. So what we do, so these also form the basis of the board assurance framework. So board assurance framework will do a closure report at year end, which will either identify things that are completed or that transfer into new objectives or new risks on the risk register. So that and we'll take you through that. And I can't, Sarah might know which board meeting, but that will come to a board meeting. So we close off each and every one of them with either completed, still on the high level objectives, or as a risk item on the risk register.
I think it's July. We come back to that, so it's in July. Thank you. And any other questions to Glenn? Okay, super, thank you. And thank you, Sarah, for your work in the background on all of this. And then the Board Assurance Framework and Risk Quarterly Report. Over to you, Anne.
So really this paper here is just to receive a note to the Board Assurance Framework for Q4 and just to receive a note to the red risks on the divisional risk registers. And if I may, just to flag with Board of Directors the good assurance that's provided by the divisions with the movement of risks on and off the risk registers. So there's some great work underway within the divisions in the implementation of the internal audit risk management review, where they went through in some detail the divisional risk registers. So that's really part and parcel of continued assurance around our work. Thank you.
Okay, that's great. Thank you, Anne. Any questions to Anne? Fiona, you look perplexed. Back with you, Rosemary. Sorry, not Fiona, Rosemary.
Yes, it's just an observation on the risk appetite, which is very new into this. They've been coloured red to green. I'm not sure whether that coloration is appropriate in all settings, because basically it means that if we're being averse in our risk, that's good. And if we're open in our risk appetite, that's bad. Now that's not necessarily the case. In lots of areas we want to be open and taking risks, and we're only going to make change if we do. So I just think perhaps some thought to go back for future in terms of how that's presented.
I think that's a good challenge, Rosemary. Thank you. We just have a reflect on that, Anne, because we don't want to inadvertently be saying that having a high risk appetite is a dangerous thing to have by being coloured red. So I think it's just worth having a reflect on. And any other comments on that? Okay, colleagues, happy to move on. So we then on to summary of ratified policies. Anne, back with you.
Yes, they're here for information, the staff car parking policy and medical devices policy. So happy to take any questions on those.
Oh, that's great, thank you. So this is just standard stuff. Any questions, Dan, on the ratified policies? Okay, duly noted, thank you. And then we're on to the summary of reports for noting and information with you, Gertie.
Thank you, Chair, and hopefully my audio will work through. This is an opportunity just to share with members of the public the staff survey results. The staff survey is a really valuable insight into colleague experience, and it's important because the everyday experience of our colleagues is so incredibly important as it goes to the heart of delivering safe, compassionate care. The period that the staff survey was completed was last autumn, so October through to December, and we have to reflect on this being a really challenging period, 18 months into the pandemic, the increasing pressure around recovery and the rising wave of Omicron. Our staff have done incredibly well, and the results are still very positive. We have seen a decrease in this year compared to last year, which is reflected across the NHS nationally and across the sector in which we are in. Our results are still incredibly positive, with SWFT being in the upper quartile and often in the top 10% of those responses. It does highlight some areas for us to continue working on. One really positive area, and an area the board is focused on particularly, is race equality. That we have seen an improvement in these areas, but again, huge amount of work we need to continue to do. We've seen equally some notification that we need to do more around disability and equality around that, and it is an area that we intend to focus on. I've set out in the report the areas that we're going to do in terms of moving forward and next steps about the launch of the people experience strategy, our values and our behaviours, and developing the trust level and divisional staff group level responses. I will leave it at that, Chair, as I think the report covers it, but I'm happy to take any questions.
No, that's great, thank you, Gertie. It's clearly been a very tough year for the NHS overall and our staff, and that's reflected, I think, in the national results as well as our own, albeit relatively we've performed again very well, and that's due to the quality of leadership and motivation that you and others provide in the trust. Glenn, over to you for a perspective.
Yeah, I can't let this go by without making my usual comment that this is the most important indicator that we get every year. So we discussed this obviously in workshop this morning. We'll be all over the numbers. I mean, one thing is our year-on-year changes and comparisons to other organisations, but as we discussed earlier, just looking at the difference between individual teams and departments within the organisation gives us some great insight. So it's our aim to just keep pushing and getting better on this, because we want to recruit and retain the best people.
Yeah, no, great, thank you. Any other questions on the staff survey results? As Glenn's indicated, we had a big session on this in this morning's workshop. Okay, still lots to do. We're on a journey, but we're in a better place than others. So thank you, Gertie. Gertie, any enthusiasm to get to the staff survey results? I think you missed the Guardian of Safe Working annual report. So should we just go to that, which is what I was expecting you to do? You threw me a bit of a dummy. So
sorry, apologies. David Adalami has already presented that, Russell, so I think he did mortality and safeguarding together. Okay, fine. And bless him. So as this is the point where we should have been discussing it before he did a runner. Any questions on the Guardian of Safe Working annual report? Okay. You can give him the fiver later, Gertie, thank you. So we then move on to the update on non-executive director appointments and voting rights. I'll take the paper as read, but just in summary, I'm delighted that first of all, Yasmin, who's been with us now since last March, is going to become a voting NED. So that is with immediate effect. So thank you, Yasmin, for all of your hard work. I think you've made a very strong contribution already in terms of the discussion around the ball table. So thank you. Through the Council of Governors Nominations Committee, we've been out for a recruitment of 3 NEDs. We've appointed 2, and I'm delighted that Richard Colley and Phil Gilbert are joining us effectively now. And also, Glenn's touched on it earlier, we have been developing our relationship with Warwick Medical School. And as a result of the solidifying of that relationship and our move to become a university trust, I'm delighted that Pamela Gill has joined us as an appointed NED from Warwick Medical School. And I'm sure the combination of those 3 talents will fare us well as we move forward as a trust. We're obviously doing pre-planning because some long-serving NEDs, for example, Rosemary, is due to leave us later on this fiscal year. So, and we've obviously lost Bruce recently. So we are preparing for the future, and I think we're preparing well with the NEDs that were appointed. So welcome, everyone. Any questions on that paper? We're not getting rid of Rosemary yet. She can't escape. It's like the mafia. Once you're in, you're not allowed to escape. So we then move on to the board committee minutes. The first of which is the Clinical Governance Committee held on the 9th of February. David, is there anything you want to add?
No, nothing I want to add to this.
Okay, great. Any questions from colleagues? Please raise a digital hand. And so we're on to any other business. So any other business, colleagues, please raise a digital hand. Okay, can't see any hands raised. So we go on to questions from governors and members of the public. Sarah, I think we've had some provided to us. Would you care to read them out for me, please?
Thanks, Russell. So we've had 3 questions from Roger. 2 of them are linked, so I'm going to read those 2 together. So under the 22-23 financial plans, there seems to be dichotomy between the trust submitting its financial plans to NHSEI and the allocation of funding to the ICS, with no agreed formula for dividing these up on a fair shares basis. The second part is who oversees the division of funding, as both Swift and George Eliot have submitted bids within the fair shares allocation, but the UHCW bid seems to be autocratic, showing a silo mentality more suitable for those living in the east of the Urals. Glenn, I think you're going to respond to this.
That's just before it does. There's that wonderful programme House of Cards, which was around in the 1990s, where Urquhart used to say, "You might say that, I couldn't possibly comment." So I think, Roger, just in the context of some of your question, I think that needs to be said. But Glenn, your answer, please.
It's good to hear Sarah reading it out there. So yeah, I mean, firstly, as I said earlier, on the revenue position, we all trusts actually still have a statutory duty to break even, and that's our plan for the coming year. So I don't expect us to have to go back and adjust that, but the system needs to ensure that we do better than the current deficit plan that we're posting. So that should, and I'm sure will, focus on the organisations that are currently planning a deficit and the need for them to do better. And I think we just need to hold our position on that and articulate the fact that we can demonstrate the productivity levels that Chairman referred to and Kim reported earlier. On capital, yes, you could set out, I could possibly comment. Yeah, in my board paper, I set out the fact that, I mean, it is a problem, and I have great sympathy for organisations who want to do something strategically, but that capital allocation that we get as a system is not really for strategic capital. It is for replacement capital. And the current way of handling this nationally is that there are a lot of pots held nationally for very specific things, whether it's community diagnostic centres or elective recovery. And we therefore have to be imaginative and find ways of bidding against those pots, because the local allocation isn't really for that. And you can, I'm sure you be assured that we're holding our line on that, and George Elliott are holding their line on that, because we do need to make sure we replace the assets in line with the replacement profile.
Okay, thank you, Glenn. I'm back with you, Sarah, for the next question.
Thank you. So the final question from Roger Lloyd is under agenda item 6.5, which is the Foundation Group Strategy Committee report for the 22nd of February. It has a subheading of ward accreditation. Can this be explained, and what benefits should this deliver? Fiona, I think you're going to answer this one. Thank you.
Yeah, thank you, and thank you, Roger, for the question. So, ward accreditation is a model that has been used nationally to accredit areas of clinical practice, or it's ward accreditation, but we're going to make it team accreditation because it's not just about wards, using a more sort of triangulation of qualitative and quantitative data, so not just our dashboard but actually observation of care to triangulate that, asking patients and staff about their experience. The benefits is severalfold actually, but primarily one of allowing you to benchmark between different wards or teams to improve, drive quality improvement, drive pride within the area, and some competition between areas. Get underneath some of the softer intelligence that we gather as part of the process, and so driving, identifying best practice and sharing that more collectively. Our intention is to try and do that across group rather than just individual organisations. It's been a bit of a slow start through COVID, and it is quite intensive, resource intensive at the moment. We need to automate the process eventually, which is what the chief nursing officers are pushing within each of our organisations. But fundamentally, I think it's a good thing for both staff and patients.
Okay, thank you, Fiona. And back with you for the other questions, Sarah.
That's all we've received, Russell.
Okay, great. Thank you. Thank you, Roger, for putting in your questions. We've got a couple of minutes. If any members of the public want to ask a question, please raise your digital hand now. Okay, I can't see any digital hands being raised. So thank you very much. We look forward to seeing you at the next meeting, which is on the struggling to find my date, the 4th of May. So in the meantime, take care, everyone. There is a Council of Governors meeting next week, which I look forward to seeing many governor colleagues at, and hopefully members of the public as well. In terms of the board, I suggest we have a 10-minute comfort break and we get back together at 10 to 4 for the confidential board, which has a different dial-in detail. So thank you very much. Take care.